well as some lymphadenopathy and inflammatory mucous membranes. You might get all of those symptoms, you might get only one of those symptoms, and it might come and go quite briefly. So again, it might be something patients don't even recall on their history. Those signs will actually spontaneously resolve, even if the person isn't treated. And then adults tend to enter what's called the latent stage. Now, latent syphilis is when they are often asymptomatic, but they will still have positive serology without necessarily any clinical manifestations. And that's why it's very important to do antenatal testing on all pregnant women, regardless of if they have any history of symptoms or current symptoms. And late syphilis is divided into two phases. So there's what's called early latent syphilis, which is that latent period in the first 2 years, and then late latent syphilis. And while sexual transmission of syphilis tends to occur in those early stages, congenital syphilis transmission actually can occur in all of those stages. And importantly, a large bulk of the congenital syphilis cases occur in that latent phase. So when women will be asymptomatic and may or may not recall any of the signs that occur with primary and secondary syphilis. Now, how does it present at birth? Well, the primary presentation is stillbirth. And then of babies that aren't stillborn, the vast majority of those babies will also be asymptomatic. I might try and just get rid of that so that, yes, there we go. Move this down so that just to make sure that, there we go. Thank you. I think you magically did that. So really looking for a symptomatic baby, that means you're finding the tip of the iceberg for congenital syphilis. And so it's really important we think about congenital syphilis for stillborn babies, for premature babies, for low birth weight babies, and then for the small proportion of babies that do have symptoms. I've got here a table with the most common symptoms that you would tend to see. And again, I'm sure you all recall these from medical school and your training, but, you know, hepatosplenomegaly, rashes that typically affect the palms and soles, and the snuffles, which is actually a really highly infectious state, are some of the most common symptoms that you will see, as well as abnormal long bone x-rays. Now, the WHO pocketbook for management of sick children, which hasn't been updated for over a decade now, recommends, yes, it's definitely in need of an update. So I'm just going to try and move this as well. So they can see it. That's good, as long as everyone else can see. So the WHO pocketbook recommends that asymptomatic babies born to women with positive syphilis serology should receive benzathine benzyl penicillin as a single dose, and on being able to access maternal and infant serology. Sometimes in some places it's possible to do PCR of placental tissue, which can be certainly a much easier test to interpret, but can be difficult to arrange. And the challenges you can see, which I'm going to talk about within this lecture, is that all of this relies on there being a lot of available penicillin, parenteral penicillin, which is increasingly challenging globally. Now, interpreting syphilis serology is something that you'll probably do less if you work in pediatrics than perhaps adult clinicians will, but you will certainly get calls around understanding a mother's serology that might have been done in pregnancy, as well as ideally, if there is ever any concern about a baby having congenital syphilis, you would also do paired serology at birth, which includes serology for both the mum and the baby. And interpreting syphilis serology is very, very difficult. There is both non-treponemal and treponemal tests that are done. Different labs have different orders that they will do those tests in. And I'll talk about some of the different management algorithms that are around that can help guide you in your treatment of the baby, depending on what that serology shows. Fortunately, there are rapid diagnostic tests that are increasingly available. And as was mentioned at the start, some triple elimination programs have commenced in, sorry, thank you. Some triple elimination programs have commenced in Indonesia that would be using these rapid diagnostic tests. That takes away the challenge of interpreting complicated treponemal and non-treponemal serology, but they're not perfect tests. So while they have done a great job improving the coverage of antenatal syphilis testing, and we know that they're cost effective, the issue is that they can't differentiate what stage of syphilis a woman may be in if their test comes back as positive. So what will often be done is many women will receive 3 doses of parenteral penicillin based on a positive rapid diagnostic test. And sometimes that can be very difficult to administer because it requires perhaps a woman coming back to the healthcare facility multiple times, which could be challenging both from opportunity costs of, leaving their family, leaving their work, as well as expensive for the healthcare facility to give these sterile injections. And so while RDTs have been very good in upscaling the availability of antenatal testing, they have certainly come with some caveats. And so current research is focusing on developing some tests which will combine both those treponemal and non-treponemal tests, because at the moment they rely on just the treponemal tests that can't distinguish that phase of infection. And hopefully that will enable some more judicious use of treatment in pregnancy and preserve some of the penicillin supply issues that we have. So as I mentioned at the start, syphilis is really surging globally at the moment. This is a recent paper that was just published last year that, noted that this is an infectious disease that has been around for centuries, but we've really done quite poorly at controlling, and we're now seeing it rise across both high and low income countries. I thought I'd quickly show some graphs from Australia and the USA to give that high income country perspective. As I mentioned at the start, there's some states in the USA that have had an enormous burden of syphilis emerge, but overall there's been a 200% rise in the last 5 years. And in Australia, we've had a 300% rise in the number of cases over the last decade. So this isn't just a problem confined to resource constrained settings. Now, this is some data from the WHO that looked at the congenital syphilis rates by region, and you can see the Southeast Asia region is really quite reassuring. But I think there are concerns that a lot of the data that we see that shows these lower rates in Southeast Asia compared to Sub-Saharan Africa, which has been renowned as having the highest rates of syphilis globally for quite some time, is probably because more research on syphilis is done in Sub-Saharan Africa. And so there are more surveillance studies that are giving more data. And I'm going to touch on why that might be over the next few slides. So when you look at the number of antenatal care attendees that are tested for syphilis across each global region, you can see that Southeast Asia has some of the lowest proportion of testing rates. Only 7 countries report doing systematic antenatal care testing to the WHO. And even those countries that do have quite low coverage of only about 30%, but with a very wide margin of none to 99%. So that helps explain why graphs like this might reassuringly make us think that Southeast Asia is preserved from the burden of congenital syphilis, but without good data that is, reflective of the information coming from antenatal care programs, it might well be a hidden burden that is underreported. This graph shows the syphilis testing coverage across 14 high priority countries that the WHO targets in terms of improving congenital syphilis outcomes. And you can see, looking more closely at Indonesia now, that coverage has been quite low over the last decade, though I'm sure these numbers have significantly improved since the rollout of the triple elimination program. And this shows the antenatal syphilis treatment coverage across those same 14 high priority countries. And again, you can see, many countries in Sub-Saharan Africa have reached quite good outcomes in terms of their treatment, but that is probably largely because of a focus on both surveillance and testing and treatment there. And I think we have a lot of room to improve this across Southeast Asia. Now, as I mentioned at the start, syphilis really is a infectious disease that suggests that there's room to improve healthcare delivery and access to healthcare for pregnant mothers. So in Australia, most of our syphilis cases come from people living in rural regions and from our minority populations who might be too scared to come to hospital, who might not feel culturally safe coming to hospital. And we do a very poor job of providing good healthcare to those groups. So the WHO says that we should be aiming for a target of 50 per 100,000 live births. And in fact, that was a target that they wanted us to globally achieve back in 2007. But the most recent numbers show that our current congenital syphilis cases are 425 cases per 100,000 births. And this is the cascade of care that needs to be enabled for congenital syphilis rates to decline. So first, you need to have good antenatal care coverage. And the target for that is that 95% of women in a country should be able to access good quality antenatal care. Of those women that get to antenatal care, you then need to be having high rates of testing for syphilis, including all those asymptomatic women, given that that's the most likely group that will transmit congenital syphilis. And then of those women that test positive, you need to then be sure to have at least 95% of those women having access to adequate treatment with penicillin. So all of these targets, though, rely on available, affordable, and sensitive tests, as well as the availability and affordability of penicillin. When we look at those targets and how we're doing globally, you can see there is certainly a lot of room to improve. So remember, this was the first target I mentioned before. The second target. So first of all, we need 95% of women getting to antenatal care. Then of those women, we need to be sure that 95% will be tested for syphilis. So when you look at this global map, you can see there are parts of Asia that have very good testing rates, as well as some countries in Africa. But there are many regions of the world where this data either isn't available or those targets are a long way off. And then of those women that test positive for syphilis, we need to ensure that 95% at least of those are adequately treated for syphilis. And again, looking at this map, you can see that this is a little bit better than the testing map, but you can see that there are many parts of the world where, even despite the positive test, there might not be accessible and affordable and available penicillin to treat those women. So why do we rely so much on penicillin for the treatment of syphilis? Parenterally derived penicillin has been the treatment of choice for all stages of syphilis for really since we've known about syphilis forever. And a lot of that actually doesn't come down to good clinical trial data that we often insist on having for most treatments these days. It comes down to just clinical experience. We also know that penicillin has good pharmacokinetics to enable the active killing of Treponema pallidum. And that's because the bacteria has a slow growth rate and requires a prolonged antibiotic exposure for effective killing. So the minimum inhibitory concentration, so just a marker of how resistant or susceptibility bugs are to antibiotics for any non-ID clinicians in the room, that is very, very low for Treponema pallidum and penicillin, which is why we're able to give good doses of penicillin that last a long time and have that bactericidal effect for the slow growth rate of Treponema pallidum. So most of the parental penicillin programs that we have are designed to maintain several times above that MIC for the bactericidal effects. And currently, many of the recommendations include either an IM benzathine penicillin, which is administered weekly, and that attains low plasma concentrations, but can be effective for a long time. And that's currently the treatment recommendation for primary, secondary, and early latent syphilis. Then there's also IM procaine penicillin, which gets higher plasma concentrations than the benzathine penicillin does, but is only effective for a shorter duration. So that's why we need to dose procaine penicillin every day. And this is can be difficult to administer. Many countries don't have the procaine penicillin available, and obviously also quite painful for the patients having 10 intramuscular injections. And where possible, IV penicillin is the other option. But again, that requires the ability of venipuncture. On many of these small, low birth weight babies, that can be very challenging. But it is the recommended treatment for congenital syphilis as well as neuroocular syphilis because it has very good penetration across the CSF. So really, when you look back on why we rely on penicillin so much for syphilis and the challenges that therefore is creating with penicillin shortages, as I mentioned, it's clear that we're basing this reliance on very minimal evidence. The first use of penicillin for the treatment of syphilis was 80 years ago, and most of the safety and toxicity data that we rely on for kids has been extrapolated from adult studies. Since the 1980s, the US CDC has recommended parenteral penicillin as the standard therapy. But then in the 1990s, there were some concerns around the adequacy of the non-IV penicillins, so either procaine or benzathine penicillin, adequately breaching the blood-brain barrier and getting adequate concentrations in the CSF to treat congenital syphilis. But we have a significant problem with a current global penicillin shortage, and there's really very little to guide what to do when penicillin isn't available, particularly from an evidence-based standpoint. So the CDC has started to acknowledge, and you may well already be doing this, that ceftriaxone can often be used as an alternative, but we have no published data, not even retrospective observational studies, even though many of us would know potentially from a few cases we've treated that those cases have had good outcomes. But there's really no published data to suggest that it's definitely safe. And obviously ceftriaxone can sometimes be contraindicated in young babies. And when we look at the other options available, there's really no data. And so I'm going to touch on at the end a few potential options that are evolving in clinical trials. This is a map of the countries worldwide that are reporting penicillin shortages. We have a significant penicillin shortage in Australia. And as you would all know, there have also been shortages here in Indonesia. And what is driving these shortages? So alongside our huge reliance on it as a treatment for syphilis, it's obviously used for many other infectious diseases. And it's a great antibiotic because it's cheap, and it's cheap because it's off patent. But it's actually quite expensive and difficult to administer because it requires the healthcare infrastructure and sterile injectables to be able to administer. Because it's off patent, there's very little incentive for commercial manufacturers to produce penicillin. And then there's also frequently quality issues of the basis of the drug that intermittently further limit the small amount of supply that is available. Alongside congenital syphilis, it's also really the only treatment recommendation for many other infectious diseases such as rheumatic heart disease, Lyme disease, and yaws. And while there's been some really fantastic progress in the use of rapid diagnostic tests for, picking up more women with syphilis, and there was a very good guidance document put out by the WHO in 2019 on this, we're going to see as more women are fortunately picked up as having positive syphilis serology that we'll therefore need to be able to treat more of these women. So the shortage is anticipated to actually just get worse and worse. The current WHO recommendations that focus just on treponema pallidum, I mentioned before the hospital management of sick children, but the syphilis recommendations currently say that for infants with confirmed congenital syphilis, which might be either an asymptomatic baby, who has had, or a symptomatic baby, but who is born to a mother that had inadequately treated syphilis, so that might have been an insufficient number of penicillin doses or an insufficient time period between when that mother was treated and the baby was born. And the WHO recommends aqueous or procaine penicillin for those babies. But they do recommend that for babies that are clinically normal, whose mothers had adequately treated syphilis, that you can probably just closely monitor those babies. They do note, though, that these recommendations are based on very low quality evidence. And actually, when you look into the appendix of their recommendations, you can see that it's actually just 9 small observational studies that are the basis of these recommendations. The CDC, or American Academy of Pediatrics guidelines, are a little bit more complex, and they rely very much on the availability of paired maternal and infant serology. And I've summarized the 4 categories that they base their management recommendations on here. So the first is the baby that is has proven or highly probable syphilis. They assume that there's availability of molecular testing as well as serology. Also recommend some investigations, including CSF. And those babies, they recommend 10 days of parenteral penicillin for. The next is a baby with possible congenital syphilis. And for those babies, the CDC would recommend, again, 10 days of parenteral penicillin, or thinking about a single dose of benzathine penicillin. And that is a baby that is asymptomatic, but has been born to a mother that's inadequately treated. The third category is the baby who is less likely to have congenital syphilis, and those are babies that have a normal physical examination, again, as well as an adequately treated mother and reassuring infant serology. And again, when you're the clinician looking at these guidelines, it suggests, well, you could give a dose of benzapine penicillin that is 10 days worth of antibiotics that baby will get, or no treatment and follow up. And so there's very little guidance, and you can see how gray even the international recommendations are. And then finally, the baby who is unlikely to have congenital syphilis, again, the babies that have reassuring maternal and infant serology, a history of the mum being adequately treated and normal examination. Again, that guidance is quite vague. Either you could give some benzathine penicillin if you're feeling worried, or you could just follow up. And so certainly in our clinical practice, we have clinicians that have different risk profiles, and some will give all babies penicillin because they will sleep better at night, and others won't necessarily. In Australia, we have a very helpful handbook that is written by our Society for Infectious Diseases and covers many perinatal infections. It might be very hard to see that on the screen, sorry, but our guidelines, again, rely on having the availability of maternal and infant serology, which frequently clinicians find very hard to determine and interpret in Australia. And then really, most roads lead to penicillin in our guidelines. So they are, again, quite conservative and recommend in most cases that 10 days of penicillin, which we would often give IV, so that's a hospital stay, separation from the mother and baby, they would get 10 days of penicillin. Now, this was a really helpful paper because I've already shown you how confusing many of these management algorithms can be. But this paper that was published in 2019 looked at how divergent actually the global guidelines are. So I'm sure Nina can comment on the Indonesian guidelines. But really, there's poor convergence globally on how to interpret serology and what steps to do for the baby. So if you're confused, that's why, because really even the recommendations are confused. One thing that is important to note is that many of the countries have started to include non-penicillin alternatives in their algorithms because of the challenges with penicillin supply. But the big issue with this is that many of these algorithms don't then recommend that the baby is still treated as if they have not been treated for congenital syphilis, because many of the alternative regimes that you can use to treat syphilis in a pregnant mother will effectively treat the mother but won't cross the placenta. So you then have a baby who is born with potentially asymptomatic syphilis at birth, but isn't necessarily treated because people just think in their head, oh, the mum's been treated, that baby's okay. So that's a really important caveat to consider when you do see options for non-penicillin regimes. Most countries do recommend single-dose IM benzathine penicillin to treat low-risk infants. So similar to that, gray zone that the CDC I showed you and the conservative recommendations Australia have, most countries similarly are quite conservative and do recommend, if you're worried, still just give some penicillin. But that means we're likely overtreating infants, driving the penicillin shortage. And actually, if those babies have true congenital syphilis, we're possibly not giving them adequate CSF coverage and potentially undertreating the truly sick ones. So I've tried to explain some of the many challenges in managing congenital syphilis, but to bring them all together as a few dot points here, they really come down to the challenges with many of the investigations that we have, and then how those investigations are interpreted and the recommendations that are made. We need better diagnostic tests. There's inconsistent risk stratification globally and vastly divergent guidelines. But what is known is that most guidelines have all roads leading to penicillin, and we're running out of penicillin. Now, there are many areas of the congenital syphilis space where research is really very urgently needed. And I've tried to summarize those in this table. I won't talk through it, but and I'm happy to share these slides, but really they come down to first having a better understanding of the epidemiology, because you saw the many gaps in the maps that I showed at the start, and how many of the maps that are available are often based on very little data. We need to have better antenatal care programs. We need better diagnostics, and we need access to non-penicillin-based treatments that we know work through evidence-based care. And I'm going to focus in my last few slides on some of these potential penicillin-sparing agents that we might be able to use. So there's a lot of talk globally at the moment around what non-penicillin agents could and should be used for treating both the mother and potentially the baby with congenital syphilis, that might, first of all, reduce some of the reliance we have on penicillin, but also potentially be much easier options to give. So oral agents would be a focus, or agents that can be, given less frequently. Oh, sorry. And just to remind you of that penicillin shortage map, the reason we need these studies are because we're seeing shortages that are only going to increase with improved testing rates. And it's also very burdensome on the healthcare system to give these parenteral penicillin regimes that are required. And if we can find some oral options, both for mums and babies, then that reduces that need for mothers to have to come back, up to 3 times if they're being treated for late-latent syphilis to have a dose of IM penicillin. And a lot of this has come together through a new collaboration called the Global Prevent Syphilis Network. This was launched at WISPID, the World Society of Pediatric Infectious Disease Conference last year in Durban. And we are hoping to, over the near future, start to access some funding to conduct some trials in this space. Some of the key agents that we're going to be looking at with these trials are really focused on potential parenteral alternatives, as well as some oral options that may be effective and able to be used in congenital syphilis. So one of those agents that will be evaluated would be oral amoxicillin, and that's because it's a cheap and easy to administer oral antibiotic that we have lots of safety data for, obviously in children. And there have been some small studies that have shown its efficacy in adults. Another is cefuroxime, which is a second-generation cephalosporin, which is already licensed for infants from 3 months of age, and has a nice low MIC to penicillin, not quite as low, to treponema pallidum, not quite as low as the syphilis MIC, but ensuring that all of these agents have low MICs for that prolonged bactericidal killing is important, as well as ensuring that all of these agents have CSF penetration. Cefixime, which is an oral 3rd-generation cephalosporin, is another agent that is under evaluation for potentially treating congenital syphilis for similar reasons to the 2nd-generation oral cephalosporins. And then, as I mentioned, many of you might already have had to use ceftriaxone or cefotaxime to treat syphilis if penicillin hasn't been available for a baby. And that is probably a very attractive option, but really we're currently doing that without any published evidence to indicate that it is safe and effective. Finally, linezolid is another option that's being looked into. Linezolid is a fantastic antibiotic because it has 100% bioavailability. So the oral agent is just as effective at crossing the blood-brain barrier and reaching the sites of infection as the IV agent is. It has a higher MIC to treponema pallidum than penicillin does, and it can be associated with some toxicity effects. So this is definitely one that would need to be evaluated in a trial, but is certainly a very, very promising option should it be found to be effective. So the Prevent Syphilis Network is working to start to hopefully undertake some of these trials that you might, hopefully we'll see Indonesia involved in as well, that will look at both simplified therapeutic strategies as well as also improving the diagnosis of congenital syphilis. So while we have rapid diagnostic tests for mums, as I mentioned at the start, they currently don't help determine the stage of syphilis. We also don't have any rapid tests for babies. So if you suspect congenital syphilis on a stillborn or a premature or low birth weight baby, you would need to do serology or you would need to do a PCR test of the placenta. So we really need to get some rapid tests that we can also do on infants. The overall aim of this program is to identify an outpatient treatment option for babies as well as mothers and take that burden off the reliance that we have on penicillin at the moment. So just to bring it all together, syphilis is very challenging to manage and to diagnose and to treat. And I would just urge you all to start to think of it more frequently when you do look after a baby that is stillborn or low birth weight. And where possible, do serology. The more you do the serology and discuss with the experts, the more comfortable you'll get interpreting the serology. Clinical signs and symptoms, especially when a few of those signs and symptoms are there and many of the other infectious pathogens that you normally think about, are negative, they can be also a very good way of diagnosing congenital syphilis. We need better rapid diagnostic tests, both for the mums and the babies. And hopefully with improved management and better tests, we'll be able to ultimately improve the currently very confusing global algorithms that guide our treatment of congenital syphilis and reduce our overuse of penicillin. The last slide, I just wanted to mention that we are hoping to start some congenital syphilis surveillance across the Southeast Asian region. Your team have been involved in a bacterial surveillance project that we've recently done called NeoSeep, and we have a website if anyone is interested, neoseep.com. And that has been a really fantastic way to launch collaborations across many countries that you can see represented there on the map. And our plan over the next few months is to then launch some prospective surveillance that will include gathering some data on congenital syphilis cases so that, those gaps in the map that we see can be improved with time. So that was all I had to say today, but I'm really happy to take questions. And thank you so much for your attention.
Thank you, Phoebe, for very comprehensive talk. I think we have many questions in here. Probably I will start with the one in here, this room. There is any question? Yeah. Maju aja kali ya.
Thank you for a great discussion for this afternoon. I'm Carissa for Junior Non-Infection. I have some question. In there are several options as alternative medicine for congenital syphilis like erythromycin, ceftriaxone, linezolid. Is there any medicine that more superior than others?
Thank you. I'm Chelsea, currently Madia in Respirology Division. I want to ask, we have ever had a baby, a well-appearing baby case. Her mother is having a syphilis with a TPHA titer positive, and then the mother was not adequately treated because the mother have an allergic to the penicillin. And the mother was treated by erythromycin. And then the baby was born. We checked for the serology. The TPHA was positive, but not more than 4-fold increase from the mother titer. But the baby was fully woke up. And from the cerebrospinal liquid, we check for the serologist too, but the serologist was negative, but we can found the increase of cell, protein, and glucose in the CSF. And then the baby was treated and considered as a neurosyphilis. What I want to ask is the first, when do we consider the neurosyphilis? the baby is well appearing. And then the second question is there any alternative for the treatment for the pregnant mother? Like in this case, the mother cannot receive the penicillin and cannot underdone the adequate treatment. Thank you.
Thank you for two great questions. I think the second question I need to confirm, is it TPHX or RPR or VDRL?
The patient was not tested for the RPR, but the positive one is the TPHA.
TPHA.
The
Maybe
VDRL
you
was
can explain
negative.
also about the TPHA. Thank you.
Yeah. Okay, sure. Should I answer them in order? So thank you for listening and for such great questions. So in terms of the non-penicillin treatment options, I think there's lots of promising agents, but none of them have been evaluated yet. So I was more outlining those agents that you might start to see, because we're really hoping that there'll be some global trials that will be funded to explore these options. And you might start to see babies in Indonesia that are enrolled in the trial and are suggested to have any of those agents. And so I was more hoping to sensitize to that potential, but I wouldn't recommend using any of those agents at the moment because we don't have evidence that they work. Many countries around the world are already using ceftriaxone quite regularly, or cefotaxime. Those babies or babies who are treated with something else, if that's not even available, we would really hope to capture in our prospective surveillance that we're starting, because most of those babies, especially the ones treated with third generation cephalosporins, are probably having very good clinical outcomes. And if we can gather some observational data to show from this surveillance project that babies that are treated with non-penicillin options, because there is penicillin shortage, actually have done very well, then that would be the first step in providing that as an alternative in many of the guidelines. So certainly third generation cephalosporins would be an adequate alternative, and we're hoping to gather that observational data to show that in time. Now, thank you also for the great question around the mother with penicillin allergy. It's always a very challenging situation. In Australia, again, where we're very conservative, they basically say, well, you just have to desensitize the mother, but that's obviously not always possible. And also, I find it's a pretty, black and white answer, assuming penicillin's the only way, when I showed you at the start of this lecture how really our evidence for penicillin is largely on a clinical experience rather than good RCT evidence. So this paper that summarized all the global guidelines has a nice list of the many options that many women might be treated with. So erythromycin, azithromycin, sometimes doxycycline in pregnancy. We would always recommend, though, that you consider that baby as having not been treated at all, regardless of which of those agents are given. And it sounds like you've done all the right things with the investigations and also the CSF. I agree that even though that baby looked asymptomatic with those CSF findings, I would definitely be treating that as syphilis with CSF involvement and giving 10 days of treatment. The serology is very tricky. You really do need both a paired treponemal test as well as a non-treponemal test to be able to confidently put an infant in a low risk category. So what you really need, which is what Dr. Nina was mentioning, is a VDRL or an RPR test. I probably haven't got I've got slides, I'll find them, that were in my spare slides, but I thought, I won't go into serology because that'll take half an hour. But without the two tests, you really can't interpret the baby's serology and you can't compare it to the mother's, because there are many things that can give a false positive or a false negative treponemal test. And you need both the treponemal and the non-treponemal test to be able to categorize the baby. Where you don't have those available, I would suggest to always do what you did and treat for 10 days. And just, if there are challenges with accessing the serology or accessing both of the serological tests for the mother and baby, or in interpreting the serology, I would always suggest just treating for 10 days. Yeah. I don't know, you might want to comment.
Yes, I think the same, PB. So we always consider the baby not uh the mother not adequate give got the adequate treatment if it is not treated by the penicillin, the same with ours. And also if we like not really confident that the baby uh excluded with congenital syphilis, then we will give 10 days penicillin procaine. But the problem here, the penicillin procaine is not widely available even in the hospital. So we sometimes need to lower our standard and then give benzathine penicillin G.
Yeah.
Yeah.
And
So-
again, those
Yes,
because
yes.
they might also be.
Yes, yes,
So,
sure.
yeah.
Probably we are too over to treat. Yeah. So we need to capture when we only give the benzathine penicillin G. I think that's the problem. The other problem is about the serology. So the VDRL and TPHS. CDC said that don't rely on TPHS or the treponemal, but we need to consider the non-treponemal serology. So I think please, yeah, please explain further about this. Any other question? Oh yeah.
Good afternoon. Thank you so much, Dr. Williams, for the very enlightening lecture. My name is Atika. I am currently in the infection and tropical diseases rotation. We have talked at length about epidemiology and also treatment, and also what we might need to look out for in children with syphilis. What I would like to ask is, in limited resources settings such as Indonesia, what do you think are the most important things to monitor in babies with congenital syphilis? Because we might have limited lab examinations that we can perform, especially in rural areas. Thank you.
And also we don't routinely do the lumbar puncture, especially for the asymptomatic one. Yeah.
So, like, I think this is where we need rapid tests for infants. I don't think we have good solutions, really, without, because it so significantly relies on the access to serology and being able to interpret the serology. There's whether all infants need lumbar punctures or not is also one of the questions that Global Prevent Syphilis Network is looking to examine, because again, that is a test that relies on expertise, clinicians having the time to do it, labs being able to do the CSF tests, and countries differ in that some countries will all do lumbar punctures for any infant that may be possibly exposed, but other settings don't do lumbar punctures. And again, many of those babies may be doing very well. And so finding that risk benefit and cost benefit to routine lumbar punctures versus being more judicious is something we need a trial to address. And that is one of the research questions. So really in resource constrained rural areas, probably the safest thing is to go down that path of overtreatment and, you know, ideally either giving procaine penicillin, presuming that there isn't necessarily the resources or there isn't IV penicillin in the country. So procaine penicillin, or even just a stat dose of benzathine penicillin, but making sure those babies have follow-up. So a baby that does get a stat dose of benzathine penicillin should be followed up at, 3, 6, 9, 12 months. And if there's any concerns around development or any signs that are emerging, you would want to reevaluate that baby and look at retreating. So there's always that potential to just give the stat dose of benzathine, but ideally make sure that there is some follow-up in place if it's possible. And I just popped this slide up because it's a nice example of why you really need both serological tests to make any inferences around the diagnosis of syphilis. So as I said at the start, some labs start with a treponemal test as the first thing that they'll run when you order syphilis serology. Others actually start with a non-treponemal test these days. So all labs do their own thing. But if you have a positive treponemal test, which it sounds like might be the first one that's most easily available here, you still need to do a non-treponemal test because that will be the one that you can compare the infant and mother titers for. So either the VDRL or the RPR will give you the titer differentiation. And it's also that titer drop that you're looking for in a mother to ensure that she's been adequately treated. So you need to see a 4-fold titer drop in the VDRL or the RPR for a mother. Whereas even if that non-treponemal test is negative, we would often suggest not necessarily relying on that and doing another treponemal specific test. And then there's lots of things that can mess with the test just to make them even more difficult to interpret, such as the prozone effect. And, that's why you have brilliant colleagues like Nina that you can call when you're in trouble. But yes, it is challenging, but I guess if we start with trying to do both tests on mothers and babies as the first step where possible, that's a good first step.
Thank you so much. I hope this answer your question. Yeah, so clear now. About all the trouble with congenital syphilis. I think, yeah, we have sometimes not really confidence what to decide. We are not confident if it is not congenital syphilis. So then we need to give whatever we have. Then also we are having varied of the tests. Like some of the public health center have RPR, but in the big hospital they have VDRL.
Yeah.
So it's sometimes different.
Yeah.
So yeah, we need to retest it for several patients also. I still have 2 questions in the chat. So the first question is about due to the triple elimination program in Indonesia has increased cases of babies born to syphilis mother, but they are reported after they are more than 1 month old. Okay. Then the only examination at the Puskesmas is RPR both for mom and child. What should we do to do that? Is it necessary to check TPHS VDRL for post 10 days penicillin procaine? And how about the mother? Is it necessary to check it? Check it too. So it is the first one is about the test also the same, and the second one is about the follow-up. Yeah.
Yeah, thank you. They're great questions. Sorry. So can I check with the triple elimination program? Do we know what week that test is being done?
RPR.
Oh, yeah, sorry, but just the antenatal testing. Is there a specific midwifery visit that antenatal testing is done? What is it? Okay, yeah.
Majority.
Right. Okay. Yeah. So that is tricky. So yeah, if they're having their antenatal testing and treatment in the second trimester, and there isn't a risk they've then been reinfected, then those babies, if you receive an RPR for the baby and the mother that are both low, that would be reassuring. And in my mind, I would think that's an adequately treated mother with the serology and the timing of their treatment. The babies that have been born to a mother who have been tested and treated in the third trimester, that mother might have required 3 doses of penicillin, and those 3 doses may not have been given more than 4 weeks before delivery. So that might be a baby born to an inadequately treated mother. And the RPR will be helpful because if you have a baby with an RPR that's higher than the mother, some guidelines say 4-fold higher, but really there's lots of studies that show there's many babies born with congenital syphilis that don't have such a high RPR. So if you see an RPR that is, higher or even, above 4, I would just be, again, treating that baby as potentially having congenital syphilis and doing 10 days of penicillin. And then the question around follow-up serology. So that, again, many of the algorithms have guidance around which babies should have follow-up serology. I might quickly show the Australian ones again because they're quite good because they're a little bit simpler than the CDC ones. But generally, babies with neurosyphilis and babies with potentially inadequately treated syphilis, or babies born to potentially inadequately treated mums, but who were asymptomatic at birth and had just a stat dose of BPG, they're all the groups that you'd be thinking about doing some follow-up serology on. So I'll show you in the Australian guidelines who they recommend that for. And again, sorry that it's quite small. Yeah, so actually the Australian guidelines are more conservative than I realized. They actually recommend follow-up serology for any baby that you even treat for congenital syphilis. And so you can see underneath here, they suggest follow-up treponema pallidum serology at 1, 2, 4, 6, and 12 months of age until non-reactive. So in my mind, that is a huge and potentially unnecessary burden to the healthcare system, but I'll bring that up with the editors of this handbook. But yeah, usually the serology is really mainly needed for babies treated with a stat dose of BPG who may have actually been high risk, or babies not treated who may potentially have been exposed. Do you agree, or? Yeah. Yes, that sounds far more rational than this one. Yeah. So with the TPHA, there are, I guess, if there's no other tests available, the safest thing to do is to treat that mother. But there are many other conditions that can give you a positive TPHA that aren't syphilis. So it may be positive due to a non-treponemal infection, which is the caveat. But I think if you don't have access to any other investigations, the safest thing to do would be to treat that.
Fortunately, I need to end this session because we need to go to the airport. Yes, thank you so much, Bibi, for great presentation, comprehensively discussing about many things, especially the tasks, and also raising awareness about the burden. We need to improve our surveillance and also the treatment. And thank you so much for all the residents who give the questions, because it's increasing our discussion today. And also thank you so much for all the participants in the Zoom. I think it's good to raise awareness about congenital syphilis, because I think in the near future we will see more cases, because yes, we know that it is global problem, not only in Indonesia, but also in many other countries in the world. I think tutup aja dulu kali ya. Okay, thank you so much for all the participants in the Zoom and in this room. And after this, you can download your certificate and also upload it in the LMS to get the SKP. Mbak Ririn nanti itunya sertifikatnya nanti dibagikan, nanti bisa di-download dan dimasukkan ke LMS masing-masing untuk mendapatkan SKP. Mungkin demikian. Thank you so much, and a good afternoon, and wassalamualaikum warahmatullahi wabarakatuh.
Miss Jessica Ramsey. Okay. And Michelle Harrison.
So, PB is the lead investigator for Neocall. Yeah, you know all about Neocall, right? That I always call you, please help. Okay. Yeah. Okay, thank you so much. Yeah.
Tangannya tinggi benar. Tangannya tinggi benar. Ya, tangannya saya. Ya, ini tuh. Jadi PEB perempuan yang kenal, tangannya tinggi benar. Ya.